Поехали, да? Okay, Manfred, so we can start. Interpreter hears you, which is very important.
Okay.
And I will start first with a big gratitude to you because still you are one of the most popular speakers of our channels and people are watching you every week. And this is very interesting to see how the part one is being watched every week.
Thank you.
Let's start with part two. What we know now, can you clarify if the vaccine against COVID makes people less contagious or not? And does vaccination against COVID affect transmission? If yes, then how?
Okay, I think the answer
Фамилию
is...
вашу напомните?
Manfred, wait, because we have somebody speaking from Zoom. Все, кто нас слушает, убедительная просьба, выключите, пожалуйста, свои микрофоны в Zoom, потому что мы не слышим спикера, а слышим только вас. Спасибо. Операторы выключили микрофон? Да. Yes, Manfred, please continue. Yes.
Okay. Basically, to understand the process, when you get vaccinated, it generally means that you're going to get either you won't be infected or you'll be infected with a much milder illness, usually. And that generally will mean that you'll have a much lower viral load. In other words, you'll have less virus. So even if you do get infected after you've been vaccinated, you are probably transmitting much less. We cannot say at this stage that you do not transmit, but it does seem to reduce the transmission substantially.
With the same question, is this the idea behind the vaccination of children? What is the goal of vaccination of children? To reduce transmission or to protect children against the disease? What is the main goal of this?
I think the goals are really twofold. The one is certainly to protect the children, even though they generally have a mild illness. But it still does affect a number of children quite badly, and they do sometimes have long-term effects from the disease. And clearly it affects transmission. It affects transmission between children, but it affects transmission to the family. So it's protecting the family. So it's actually very good for the children if it's protecting their parents and their grandparents and their siblings. So in that sense, it's good for the children, both for themselves, but also because it's protecting those around them.
So we indeed believe that the viral load will be lower among the vaccinated.
That's what we understand now, right?
Okay. So the next question will be about children. Israel covered all children over 12 years old for the moment, correct?
That's right, yeah.
With Pfizer, correct?
Right. We are now starting to use Moderna. Yeah.
What do you think? Which vaccine will be the next to use for children after Pfizer? And will the age group somehow widen and be less than 12 years old?
Right. Firstly, I think that all the vaccines will probably be fine for children. It's just a matter of time to make sure that the dose is right and that there's no real problem with side effects. We don't expect anything unusual. So the Pfizer is currently being used. We also will be using Moderna. And the expectation is that they'll get much lower doses. So now they're talking about a 1/3 dose, maybe only 30% of the dose, or maybe even less. So children will probably develop a good antibody response with a much lower dose.
Do you think that it will start soon for the children with the lower age than 12?
I would expect that right early on in the pandemic, I was one of those who believed that you have to vaccinate children. And I'm sure you will agree that there's really no disease that we've been able to control without vaccinating children, because they will still be spreading the disease and some of them will get very sick. So I think we have to make it clear that vaccinating children is part of the program to control the pandemic and also to protect children.
Mm-hmm. And do you think that US or Israel or Canada has plans to go ahead with vaccinating the smaller children for the moment, or there are no results of clinical trials yet, and it's a question of 1 year. So what do you think when the time will come for the smaller children?
I understand that they have some early results now from the ages of under 12. In other words, probably around about 2 to 12 or 4 to 12. And they seem to be good. There's no unusual side effects, and the antibody response is good. So I think that will be the next group that we'll be vaccinating, and also abroad. And I have a feeling we'll be vaccinating even the very young kids at some stage, probably even 2 years old. That could well be. These are good vaccines, and they're all inactivated vaccines, so there's no concern about, although there's no reason why we should worry about live attenuating vaccines, but at the moment they're all not live vaccines. They're not live vaccines.
What about pregnant women? Because there is a difficulty in Ukraine as usual, as it was with the vaccination against influenza. And we know that vaccination against COVID is recommended for pregnant women. And we know that Israel is doing it. So how this one is going, what do you see as the safety profile for them? What is the attitude of pregnant women themselves? And does the antibodies go to the unborn baby, and does it protect the baby after birth? What is the effect on the baby?
Right, so the vaccinating pregnant women, as you said, is very important. We know this for influenza. We actually vaccinate pregnant women routinely against tetanus, diphtheria, and pertussis, primarily to protect the babies, as you know. But there are no problems with these vaccines. And again, if they are not live vaccines, there should be no problem vaccinating pregnant women. And in fact, we know that for diseases like influenza and now COVID, pregnant women can become very ill. And we've unfortunately had deaths from COVID among pregnant women. So we very strongly recommend vaccinating pregnant women. This must be discussed with their own physicians, but this is our belief.
Is the attitude of pregnant women themselves favorable to this vaccine? Do they want to get vaccinated in Israel?
Generally, yes. Generally now they understand that it's, and the doctors also understand that it's a very important vaccine for pregnant women. And in fact, there is no real recommendation at any time in the pregnancy, but you know, if you are a little bit concerned, you could do it in the second trimester or the third trimester if you, although there's no reason not to give it in the first trimester, but you could give it later. And I'm sure that women are getting it in the first trimester because they don't know that they're pregnant, and we've seen no problems with it. So basically, it doesn't seem to be a problem.
With regard to the newborn, does the newborn receive the antibodies from mother? And if yes, then does it play any role in the protection of the newborn against COVID?
The answer to the first question is that there is evidence of transmission of antibodies to the baby, to the newborn in utero. It's not altogether clear to what extent they protected and for how long, but it's obviously a good thing. I mean, it's certainly good to see that that is actually happening.
One of the most popular topics for the discussion is the third dose. So people are speculating around the third dose a lot in Ukraine, saying, oh, if the third dose is needed, that means that vaccines are not effective. So what is the policy with the third dose in Israel? And what do you think in general as the specialist in this field with regard to the third dose? When, for whom, needed, not needed, evidence-based, not evidence-based?
Okay, I think that, you know, I'm talking to you who know so much about vaccines, and probably many others in the audience, that it's very common to give more than 2 doses of a vaccine. In fact, most of our vaccines like tetanus and diphtheria and pertussis and whatever, we give 3, 4, 5, 6, 7 doses sometimes. Polio, we give a number of doses. So the idea of giving more than 2 doses doesn't mean that the vaccine is not effective. It just means that you sometimes need more doses to make sure that there is a good, strong antibody response and a long-term memory. What we have seen for the COVID vaccine is that the booster dose, the third dose, gives a very good increase in antibodies, very much better than the second dose, which is very impressive. And that's the same kind of thing as that we've seen with, for example, with hepatitis B, where we give 3 doses. So it looks to me, at least from the data that we're seeing, that the booster dose is very effective. So if you can afford it, we have to make sure, first of all, that everybody gets the first and the second dose. But then we would go on to the 3rd dose. I think that should be part of the schedule. It should be, in my opinion, it looks like it should be a 3-dose vaccine.
And this issue with the 3rd dose, did it appear because of Delta, or it appeared just because the antibodies were dropping, or why in general this discussion started about the 3rd dose?
You know, I think the answer to that is both, because we basically saw 2 things. We saw a decline in antibodies, not necessarily very dramatic, but certainly a decline. But we did see quite a number of breakthrough infections, and that was particularly with the Delta. But, you know, I received my booster dose two weeks ago. And I did serology just for my own interest afterwards. And there was a very high increase in antibodies. And that seems to be very effective also against other variants. So if you have a very high antibody level, it seems that it's covering to a large extent other variants.
And what is the regime for the moment? What is the 3rd dose? What is the interval between the 2nd dose and the 3rd dose?
Right, this is a very important question, and I think that, to my feeling, we were, for some reason, a little bit worried about the spacing, and for Pfizer, we said it had to be 3 weeks after the 1st dose and so on, but as you know, and many of us know, there is no minimum, there is really no maximum interval between the 1st and the 2nd dose. Usually there is a minimum interval for measles or for any of them, so you can give it, you know. So I think here, waiting a bit longer between the 1st and 2nd dose was probably a good idea, which they did in the UK. So it's not really a big deal if you wait for a month or 6 weeks or even sometimes 2 months. So I don't want to interfere with your own schedule, but what I'm saying is that delaying another dose can be good. For the booster, I would say anything from 6 to 8 months after the 1st dose. After
6 to 8 after the 1st or after the 2nd dose?
Yeah, about 5 to 6 months after the 2nd dose. But again, people should not be concerned if they're a little bit delayed, because it doesn't really affect it very much.
But what, for example, if interval between the 1st and 2nd dose exceeded for 6 months? Do doctors have to give, for example, we had several practical cases. Like a person would receive the AstraZeneca by Indian origin, like I received, for example, Covishield. And then some people simply forgot that they have to have the 2nd dose. It was summer, they spent nice time on the sea, and then they finally woke up in 6 months that the 2nd dose was never given to them. So what is the best regime for these people? Just to receive the 2nd dose, or to receive 2 consequent doses, for example, with 1 month apart?
Yeah, I think at this stage, we don't, this is another very good question that you ask. And I think we should maybe we can work together on a small research project and look at the antibodies, but we don't have some good data on it. But if we look at other vaccines, if you wait, you generally, if you have a good priming dose at the beginning, and this vaccine is very immunogenic, or most of them, I wouldn't be too concerned. I think that somebody who misses the 2nd dose gets the booster. I'm not sure that they may need 2 more, but I think they should start off with 1 dose and then wait some time before they get a booster. So not give it like very close to each other. So maybe at least this is my feeling. As I say, I don't have the best data, but if you look at other vaccines, I would say get the 2nd dose, even though it was delayed, and then wait a couple of months, wait a few months, and then get the booster.
So Israel is giving the booster already, right, to the citizens?
Yeah, you've given more than 3 million.
But to whom? To everybody, or only to high-risk groups? To whom is this booster going?
We started off with the age over 60 and people at high risk, in other words, immunosuppressed and so on. But now we are giving it from age 12. So everybody is getting it.
So totally everybody is getting booster dose,
Right.
everybody who is eligible for the vaccination. How do people perceive it? Do they easily agree for this? They don't? Is this growing as a coverage?
No, I think there is a little bit of hesitancy among some people. So, you know, it's taking time, but a large percentage already have taken the booster dose. So it seems to be well accepted generally. But I might add that I think that Israel, like everywhere else, we should be part of the effort to make sure that everybody in the world is vaccinated. So if you tell me that we need to help Ukraine, then you must tell me how to do it, because I think we should be helping. Do you have adequate vaccine? Because that would be something I would ask.
For the moment, we of course have vaccines, and we have variety of vaccines in the country. But unfortunately, due to all different mythology, which we will discuss a bit later in this interview, and I will be asking you questions on it, we don't have that much of uptake as we would like to. However, it's growing. Okay. So coming back to the questions of the regimes and doses, for the moment, do you think that this will be a 3-dose vaccine and that's it, or there will be a 3-dose and then a dose every year? So what is the global discussion on that for the moment?
Well, again, you and I know the questions that we ask even about the pertussis vaccine. How often do we need to give it, or tetanus? So I think it's a little early to do it. But as I said, I'm very encouraged by the results of the response to the 3rd dose. And so I think that it may be that that will be good for a long time, but we will have to follow the data very carefully, but I think it will be. But as you know, as we have with other vaccines, sometimes we need to give boosters later on.
Do you think it will become a seasonal yearly vaccine like influenza or not for the moment?
You know, it looks like it. There doesn't seem to be any evidence that the virus will one day disappear. It's likely to stay with us. It will be what we call the 5th coronavirus that is now endemic. The others mainly either causing, so the endemic ones, the ones that are causing the common cold. And of course, the one that disappeared, SARS, which was 2003, was a very severe one, which produced very severe disease and was quite easy to isolate the patients. And that probably was the reason why that virus disappeared. But it's very unusual for a virus to disappear, as you know. Almost never. Usually a virus that gets into the human population remains with us. I think that we will probably have to live with it as an endemic virus.
There is a big discussion in Ukraine with regard to the efficacy and efficiency of vaccines in a way that people still get sick after being vaccinated and people still would die after being vaccinated. So people are reading the news from other countries, searching for this news in Ukraine and saying, oh, your vaccines do not work. So do vaccines work or not? And what would you say about the person who still got severely sick with them after being vaccinated or even died after being vaccinated? Why would such situation happen?
First of all, we know that the vaccines are not 100% effective. So we know that people can get sick from, even though they've been vaccinated. We generally, though, see that people who are vaccinated get a much milder disease. But there is a possibility of getting a severe disease. So really the answer is twofold. One is for the individual, you reduce your risk, like everything else. You reduce your risk very substantially if you get vaccinated. Just like taking a medication. You may not everybody benefits, but you have a very good chance of being much better off. The other aspect is that if we can reduce the circulation of the virus, if there's a high level, let's say that in Ukraine, 90% get vaccinated, there'll be very little virus circulating, which means that not only will you be protected from the vaccine, but you won't be exposed virtually. So basically it's a two-pronged effort. It's to get people vaccinated so it reduces very much their risk of getting very sick, but it also reduces the circulation of the virus and it reduces the chance that you'll be exposed at all. So I think this is really the message.
So if somebody dies after being vaccinated twice, that means that this was a non-responder, most probably.
Most likely, that seems to be the most likely, which can happen with vaccines, as you know. So we do occasionally have that.
How
Usually
fragile are these vaccines? I mean, from the temperature perspective, how quickly they can become ineffective because of the bad storage, or they are very stable?
Well, the Pfizer one, as you know, has to be kept very closely monitored for heat at low temperatures. The Moderna is a little bit more flexible. I know that they're stabilizing these vaccines much better now so that they're more stable. So I think that they are much better now, but you still, as you know, for the Pfizer one particularly, the cold chain is very important, keeping it cold.
We see some numbers of cases of the second disease, so to say. I mean, with somebody who had the PCR confirmed corona infection, symptomatic, and then in several months, the person has another episode of the symptomatic corona, sometimes on oxygen, sometimes or not. So what do we know for the moment about this disease, how the natural immunity works or it doesn't work, whether it lasts, doesn't last, on what does it depend?
Well, as you know, there are many studies now on what is called long COVID or some remnants of COVID. You know, I'm always afraid someone will say it's creating panic, but this is a very serious disease if you get it. If you get COVID and you are symptomatic, particularly in China, it can be a very serious disease, as you know. But not only that, the virus does seem to have, in some people, long-term effects. It's probably even related to the fact that initially, even in the disease, the virus is more problematic, and then later on you get this immune response, which becomes problematic in itself. So it's, you know, people who say, oh, it's better to get the disease naturally, I would not recommend that. That's not a good idea, because it can do lots of things to you other than the actual disease. You can have these long-term effects. So many of the long-term effects are fatigue, or muscle pains, headaches, generally, you know, but for sometimes for several months afterwards. So it's in a small percentage maybe of the population, but it's not irrelevant. It's, you know, it could be a significant percentage of the population who would have these long-term effects. We know that this can happen even with influenza, by the way, but much less. But with COVID, we're seeing it a lot more in the so-called long COVID. So the message again is get vaccinated. It's better to get immune from vaccination.
An interesting thing that the long-term effects of COVID might be related to the immune response, to the natural immune response to the disease itself. Can you elaborate a little bit on that?
Well, basically, I emphasize that I'm not an immunologist, but the process of the disease is basically the virus, which often happens in the virus replicating in the body and doing damage initially. Then there is an immune response to the virus, not necessarily, and there is the so-called, sometimes some of them call it a cytokine storm, or it's basically an over-response of the body to the attack from the virus. And this in itself then can create what we would have this hyperimmune response. And this can cause damage in different parts of the body and can have long-term effects probably.
And when we speak about the immunity to the vaccine, do we count only on antibodies or we count on cells as well? So what is known up to this moment?
Well, we know, first of all, that as you say, there's a very good humoral response.
Manfred, you disappeared.
Okay, I'm sorry, it's a problem with my internet.
It's okay, I can hear you now, but I can see you. Yes, I can see you and hear you, it's okay.
Okay.
So we stopped at the moment when it was about cells and antibodies. So how is this immune response built?
So you get a good antibody response, but you also get what we call the memory response. In other words, you have cells in your body that are retaining memory of the antigen. And that will then respond very rapidly when you get exposed to the virus. And the vaccines, as I understand, basically all the vaccines are producing a good memory response. Some are a little bit better than the others, but the vaccines that have been that are really in use now seem to be effective. No, they are effective, but also on the memory side.
So the question is quite practical in this case for Ukraine, because people are running to check their level of antibodies after being vaccinated, the antibodies against spike antigen. And if there is no antibodies, they are panicking that vaccine didn't work. So should they measure the antibodies? Do people do it in Israel or not? Does it really show whether the vaccine worked or not? What would you say about this practice?
Well, first of all, we don't recommend it here. We don't recommend that people test for antibodies. And I'll give a couple of reasons, although we do it for research. So people who are in studies, we do it, but not routinely. There are two problems with checking antibodies. We know that people who have had the disease can sometimes will not have antibodies. We can't see detectable antibodies. So that's also something that seems to decline, not only from the vaccine. And there is evidence now that even though there are no detectable antibodies after the vaccine, there is this memory response. So they still respond to a booster dose. So really, I can't say to you that there's no value, because I guess you're right. From an immunological point of view, if you have high levels of antibodies, that does seem to indicate that either you've been exposed or you've been vaccinated. So I would say not do it routinely. I wouldn't be too worried about it. As we do with most vaccines, basically, we don't actually test antibodies afterwards. So I would say not to, I would not recommend it. I think it would just cause anxiety.
Yeah, it is what we see, a lot of anxiety. So if
Right.
there is no antibodies, should I do it again? And things like this.
If you've received 2 doses, that's great. And if you can receive a 3rd dose, I don't know how easy it will be, but that would be excellent. I wouldn't be too worried. Yeah.
Mm-hmm. Coming back to the efficacy of the vaccine, for whom does it work best? Which is the age group which shows the best result in response? Or you can say like this?
No, I understand your question, because generally with other vaccines like hepatitis B and even influenza, we see a decline in the efficacy with age. Interestingly, with these vaccines, there doesn't seem to be much decline with age. It still seems to be very effective in the elderly. So it's maintaining its efficacy even in the older patients or the older people. So, so I would say that that's a good sign.
With regard to the antibodies, again, because this is one of the most popular myths, which is not helpful with regard to the coverage of the vaccine. People are routinely checking antibodies to COVID itself, because there is the belief spread by some professors that it is bad for you to get vaccinated in case you have antibodies to the disease. So is it bad for the person to get vaccinated if the person had clinical or subclinical or without symptoms COVID?
Well, there are couple of answers. First of all, we know that we've been vaccinated people who have already had COVID because they are asymptomatic. So they were there because they didn't know and they got the vaccine. And we haven't seen anything unusual in the population that's been vaccinated. So we don't believe that it's related, and there doesn't seem to be any evidence. And the question of whether people should be worried, we are even discussing the possibility of recommending a vaccine to people who have been infected and an additional dose, because it does seem to strengthen their immunity. As I said, even after their infection, in some people at least, it does seem that perhaps there is some evidence of repeat infections. Not common, but there is some evidence. So there are some who believe that maybe it's even good to give an additional dose. It's not yet recommended routinely in Israel, but we may recommend it. We're certainly discussing to give at least an extra dose.
And for the moment, for those who had the COVID with the symptoms, do you vaccinate them with 1 dose, with 2 doses, and when do you start this vaccination?
So far we haven't made a clear decision, but at the moment we're more discussing 1 dose. The reason, and we really believe that at the moment that 1 dose would be adequate. There's no need to give another dose. But one of the reasons why people were saying give 2 doses was because internationally there may be this requirement that you have a document that says you had 2 doses. I don't think that's a good argument. I think that we should, if you have a positive PCR, that should be evidence that you've had the disease. And maybe if we recommend to vaccinate 1 dose, to me, I would say that 1 dose would be enough.
The debate in Ukraine about it is related only to the safety. So basically, can we definitely say that this is safe to give 1 dose or 2 doses or 3 doses or any kind of doses to those who had clinical COVID?
Sure, there should be no reason. And if you think about it also immunologically, if someone has been infected, it's assumed that they have some immunity, probably good immunity at least. So if they get exposed to the vaccine, it's much less than getting exposed to the actual virus. So it's just a regular boost to your antibody response. So there'd be no reason, and we're not concerned about that with any other vaccine. So maybe won't give the very strange ones, but not for vaccines that are routinely used.
Mm-hmm. What do you do with this simultaneous? For example, COVID and influenza vaccine, is it allowed for the moment or not? And what are the global tendencies in that? Because initially, if you remember, people were receiving only COVID vaccine, not together with other vaccines. So is it allowed? Will it be allowed? Is it already allowed?
Yeah, I think the recommendation for us at least, and that is that you give it in different arms. So just give 1 on the 1 arm and 1 in the other, if you're getting them at the same time. I believe that Pfizer and maybe Moderna, I think Moderna, in fact, are looking at putting it in the same file. In other words, giving it together. And that may be in the future what will be done. It will be 1 vaccine.
So it is already allowed in Israel to do it, for example, 1 arm influenza, another arm COVID, or 1 arm tetanus, diphtheria, and another arm COVID.
Sure.
Yeah.
Right.
Okay.
Yeah. There's no safety concern. The only concern sometimes with this is with giving simultaneous is that the one may interfere a little bit in the response, but we don't have any evidence of that. So at the moment, it seems fine.
So it is safe and it doesn't interfere to the response.
That's what we understand now, right?
The other question is with regard to the oncological patient, which as well, there is a big debate. So what is the policy for you with the oncological patients who are receiving their chemo or radiotherapy? Do doctors wait, or they allow the patients to be vaccinated now in order to save their life in the Delta?
Right. Again, if you look at the safety point of view, there's no problem in giving it. If you look at the efficacy, it's not recommended to give it to patients who are currently undergoing chemotherapy, because that's probably going to very much affect the response, the immune response. So you would usually wait until the chemotherapy has been done before you actually give, or at least there's a period of time after the last chemotherapy dose that you would give it. So it's not a safety concern. Again, we are not talking about live vaccines, although it may well be okay for live vaccines, but here that's not an issue because these are not live vaccines.
Mm-hmm. There are questions I can see from our viewers with regard to myocarditis and Pfizer. Is there a proof that there is a myocarditis again after Pfizer? For which age? And is it already, you know, the causality assessment was done? Is it proven or not? What is the discussion on that?
Right. We believe that there is evidence, and we will be publishing a paper in the next couple of weeks, which will come out where we've shown that there is a small increased risk. it's very much in young males. So the highest risk group would be ages 16 to 30 and a little bit maybe even from 12. It's about, in that age group, it's maybe about 1 in 10,000, almost only in males, by the way, almost don't see it in women or in girls, which is actually typical of myocarditis. Almost all the cases are mild and resolve without any problems. So it's considered to be a fairly rare side effect and generally a mild side effect. So it sounds maybe more serious than it is, but almost all the cases have resolved very quickly. So by and large, we don't see this as a problem in terms of using the vaccine. By the way, myocarditis is one of the complications of COVID itself, and that's much more common in COVID than it is for the vaccine.
And again, the question about the famous thrombosis, is there any evidence, final evidence that it is related? And if yes, then for which group? Or there is no final evidence yet?
For the Pfizer and Moderna vaccines, there doesn't seem to be any good evidence. If it does exist, it's very rare. For AstraZeneca, it has been shown to be a rare side effect. Again, pretty rare, more common in women, and but again, a very rare side effect. So, but it does exist. It does seem to have been shown.
Let me have a look on the questions from the audience. Do you have a practice recommendation to give blood thinners to the patients who are receiving COVID vaccine?
So I would say certainly not. I would not
Certainly not.
recommend it.
Okay. So is there a minimal interval between the COVID disease and COVID vaccination, which makes, let's say that if you do it too early, that it will be dangerous for the person? For example, somebody who had COVID just a week ago, is it dangerous to vaccinate this person or not?
There's no evidence that it'll be dangerous, but I think in general, from an immune response, I would wait something like 3 months. What we usually recommend is to wait 3 months, but it's not exact. If it's 2 months or 6 months or 4 months, it's not critical, but about 3 months is a good time.
But it's for the immunity response, for the efficacy, not for the safety, correct?
Yeah, the safety, we don't really see a problem with safety.
How long this absence of smells can continue after COVID? Because people are complaining, and now in the comments there are questions to you about that, and in general there are discussions among patients because of the change of taste or absence of taste and absence of smell. How long can it last, and what is the mechanism of it? Does it mean that COVID affects central nervous system?
Right, it certainly does seem to be an effect on the nervous system, and it does seem to be something that can last months. I mean, not just days. So it usually resolves fairly quickly, but there are now documentation of cases where people have been suffering for several months. So it can be a long term.
Manfred, I cannot hear you. Can you say something?
Hi, sorry.
So I will check.
Can you hear me?
No, you're here. Yeah. Can you repeat the last phrase because the internet dropped?
I'm saying that it can have a long-term effect. It can remain for a long time, several months, but it seems to be an impact on the nervous system. In other words, the nerves supplying the taste buds and so on and smell. So it does seem to have a direct effect on the nervous system. That's just for the disease, obviously not the vaccine.
Mm-hmm. There are a number of questions with regard to contacts. Let's say, for example, you are in the situation where you have the school and the teachers were not vaccinated, and then there is an outbreak among kids in the class. Would you immediately vaccinate teachers as contacts or not, or it doesn't make sense?
You know, that's also an interesting question. I would suggest that, you know, I would tend to suggest maybe that you should, but there's not really good data on that. There's not good evidence. It's not like some of the diseases where we do it, as you know, with polio, or with others where we may vaccinate contacts. So I can't really give you a clear answer. Again, I don't think there's any problem. I don't think there's a safety issue. I would tend to say, I'm not sure that it's going to prevent the disease, but that's something that still hasn't been demonstrated. But in the long term, probably it does improve the immunity of the people around. So maybe it will improve the spread, further. But again, as I say, the data is still not clear.
And when the vaccine starts working in the person, like, for example, we know with other vaccines during the outbreak with measles, and, so how is it with COVID? Let's say it's the same situation with the contacts and you give the first dose. So when do you expect to have at least some immune response, or like with influenza, for example?
Right. Well, generally, as you know, the vaccines, we usually say it'll take maybe 10 days or so before they're a little bit more that there is a good immune response. And if we're looking at the efficacy, it usually doesn't start until about 10 days to 2 weeks after the dose. So that's the general rule. But if you ask me about giving it to contacts, again, we may be surprised and find that there may be a quicker response. So it's possible, but again, I haven't seen any literature on that, anything that's actually been shown.
With regard myocarditis, there still are some questions. So you said it's among young male and it's quite rare and it goes away, right?
Usually, yeah. They are, most of them in Israel, the policy is to hospitalize, but that's for.
Does it happen after 2 doses, or it happens after the first dose?
We've almost only seen it after the second dose, and we are now monitoring to see if it will occur after the third dose. It seems to be rarer, less common after the third dose.
With regard to allergy, we had several questions during this month from patients who received the first dose of Moderna, for example, and having the allergic reaction, which was not anaphylactic shock, but it was a rash and it was a bit of swelling. And people were very pro-vaccination and they were very much interested into getting protection. So the practical question was, in this case, should they go and do the second dose with the same vaccine, or it will be too risky because the allergic reaction to the second dose would be worse than to the second?
If there's a severe reaction to the vaccine, then there is a caution. They should be careful about getting that. And that's usually if there's anaphylaxis or severe allergic reaction, not just, mild rash and things like that, which are just a mild allergic reaction. The allergic reaction, again, the mechanism is probably, it's not related so much to the protein, the vaccine, or the antigen in the vaccine. It seems to be related to the so-called, not preservative, but the medium that's used to actually inject the vaccine. So it's unusual, but again, if it's a severe reaction, we do not recommend that they get the same vaccine again. Without consultation, or at least under supervision.
What is the policy with regard to HIV and AIDS patients? We have the question from the audience.
Right, again, because it's not a live vaccine, they can be vaccinated. And it does seem that the immune response of HIV patients is quite good. So again, it's in this sense, it's an immune response which is not very much affected by the HIV. That's what at least that's what's been published.
With regard to the new trends, so as I understand, one of the trends is that children will be more and more getting vaccinated in the younger age groups. Another trend is that potentially people are experimenting with making one vaccine out of influenza together with COVID, as you mentioned. And basically the discussion is with regard to the third dose and with regard to the whether it will be a seasonal vaccine or not. What are other new trends and discussions globally on the COVID vaccines for the moment? What is interesting is upcoming as for you? What are you following? Which discussions are you following for the moment?
Well, obviously the question of vaccine hesitancy, which you said you might talk about, but the question, I'm not an expert on the treatment of COVID. There is, obviously, that's more for clinicians. But does seem to be some progress in that area. So I would certainly not recommend to somebody not to be vaccinated because there's treatment, because even with treatment, it's a severe disease. But it does seem to be that there is improvement now in actual and potential for life-saving treatment. So that's certainly something that I think we'll see in the future. It's still not very well developed. I mean, they're still trying different mechanisms, but there are some medications that seem to be promising. But you should stick to the medications that have been approved and not all these strange combinations which have no real good evidence.
And do we expect anything new in the vaccine world? I mean, the COVID vaccine world?
I think that one so-called good thing about the pandemic is that we are now learning to use the mRNA vaccines. And I have a feeling that this is going to be a new breakthrough in vaccines generally for other viruses. So it could be that that's going to be an area that will be quite interesting. That'll improve maybe the current measles and rubella vaccines, the MMR, and other viral vaccines that we're using. So that could be a potential also that we need to remember. It's a new technology, and we don't usually see many breakthroughs in vaccine, new technology. So this is really a new technology, and it seems to be very good.
So there are certain questions from the audience with regard to anti-vaccination movement and vaccine hesitancy. Do you have anti-vaccination movement in Israel, and is it big, and who is pushing it, who is promoting it, and how is it structured?
Okay, first of all, the social media has been one of the major factors, I would guess, with all kinds of strange shall we say, myths and legends about what the vaccine can do. It's not very different from what we've seen with other vaccines, but because this is a newer vaccine or a new vaccine, and it's being given so widely, that's obviously generated the possibility of people putting all kinds of information or misinformation that is not correct on the internet, and people learn from it. So that's an issue. So we do see that, and we do see that sometimes in subgroups more than in others. I think that the younger population are more affected by this misinformation on vaccines. And largely, I think, because people don't really understand how vaccines work. And vaccines, as you know, are very safe. As we know, we have a long and very good record of vaccines. And I guess the reason that they're concerned is that it's given to healthy people, unlike medication. So you need to be stronger in your belief that it's safe. But the anti-vaccine group is problematic. There is one small group of professionals who don't have any, to my opinion, again, don't have any good scientific basis, but have been also participating in the so-called anti-vaccine movement. But it's pretty small in Israel. It's very
and
small.
You said that it's a small group of professionals, medical professionals,
Very
right?
small group, yeah. But
so what is the attitude of the government to them, and are there any juridical measures which are applied to the medical professionals who are calling against the COVID vaccination?
Yeah, there's been nothing to try and actually impose any legislation or to actually charge these people with malpractice, but it's generally done through information and through messages given by the medical association and the professional bodies. So, so far it's not been done as any way of punishing these people for doing that. So we try to respond as best we can, basically.
So legally they are not persecuted, but medical associations are basically saying that these people are wrong and that this goes against the interest of the population, correct?
Right. There's not, you know, people were very hesitant to try and actually take away somebody's license. Fortunately, there are very few physicians, very few doctors who are involved in that. I mean, it's really, you know, just a handful. So it's not really a major problem. But at the moment, there's been no real effort to actually, you know, cancel their license, for example. Not now.
Mm-hmm. Because it is a problem in Ukraine, actually. It is a big problem in Ukraine. And,
amongst professionals.
Yes, among professionals, which is causing the...
I maybe tell you a curiosity of it's a daughter of a friend of ours who was told by her physician not to get the vaccine. And she became ill. And she was on ECMO, she was on a ventilator, and she, 38 years old and very nearly died. She's coming out of it. I don't know what long-term effects she'll have. But this was unfortunately due to a recommendation from a physician, which is that I would consider, in my opinion, malpractice. But again, there's not much legal stuff that we can do at the moment.
And it was in Israel, right?
In Israel, this happened, yeah. But it's very unusual, but it does happen, and that's the tragedy sometimes. And
she wouldn't go against him in the court, or she would?
It's interesting to know whether that can be done. It hasn't been done yet, but if she asked me, I would encourage her.
Another thing which I wanted to raise is the Pfizer and the reproductive function. For some reason, in the social networks and among the healthcare workers in Ukraine, there is still this very strange discussion that if a woman would be vaccinated with Pfizer vaccine or with other vaccine, but more about Pfizer, they are talking about it, that there will be some damage to reproductive function. More they are talking, of course, about women, but sometimes about men as well. And this is quite serious. For example, yesterday I was giving a small lecture in the kindergarten and the school, the private kindergarten and school. And basically 20 teachers who were in this lecture were sure that it's very dangerous for women to have these vaccines because of the reproductive function. Where did it come from? Does it have anything, you know, inside of this idea? And how should we as doctors explain that this is not like this? How you can explain the mechanism that it's not like this?
Okay, so I mean, you've already said the first part, that there is no biological mechanism, so there's no reason why we should suspect it. But the question is why this even started as an issue, and I think there are two reasons. One is that you may be, and I'm saying you may be, you're very familiar with the anti-polio vaccine movement, particularly in Nigeria, where there was a rumor going around that the Western countries were actually supplying polio vaccines and other vaccines to the developing countries to reduce the fertility, in other words, to reduce the population there. And that recreated this anti-vaccine movement against the polio vaccine, and then you had cases of polio. So it's a convenient, shall we say, tool for anti-vax people because it's very emotional, and it's easy to state without any proof. And that's basically what is being done. There's actually no basis for it, because if you think about it, first of all, the disease itself should cause infertility much more than the vaccine, because the vaccine only has one small part of the virus. It has the protein and there's no real connection with the reproductive system. We don't have vaccines that impact on the reproductive system. There may be a question about whether COVID itself does, but the only ones that I could think of was for mumps, which would maybe cause orchitis and so on. But that's the disease, not the vaccine. So there's no, and here with the Pfizer vaccine, as with others, you basically are using just the protein to generate antibody. I think one issue, though, is that people hear the term RNA, and RNA is genetic, and it sounds genetic. And I think it's confused with DNA, and it's not related. And that fact is that and in fact, if you get infected with COVID, you get DNA or RNA particularly put into your body. I mean, that's part of the virus. Here, it's basically a synthetic form of RNA, which gets broken down in a few days anyway, so it doesn't really remain in the body usually. So there is no basis, but I think it's a convenient myth. And I've heard friends of mine, young people generally, who believe that's a possibility. It's just from the internet. It's from the social media.
Can you say it once again with regard to the synthetic part of RNA and that it doesn't enter the DNA and doesn't change you into a crocodile?
Right.
Can you explain this once again a bit? Mm-hmm.
I think we just have to remember that in the body where we actually, our bodies and everybody's made up of proteins. We produce proteins and there's a process of making proteins in all our cells. What the actual viruses do, not the vaccine, the viruses actually occupy your cell and use the cell to create proteins to replicate. So if you get infected with COVID, that virus is going to go in with its RNA and all the other things. The mRNA is just one of the mechanisms where we actually produce the proteins in the actual cell. So the actual injection actually contains the code for the mRNA being not the genetic material that's in the nucleus of the cell, right in like where the DNA would be. It's actually in the cell medium. So what it's doing is it's basically instructing your factory in your cell, the ribosomes and so on, to produce the protein that is similar to the one on the virus, so that your body will actually recognize it and actually then produce antibodies against it. And that actual RNA, which is synthetically produced, just gets broken down as a foreign object after a few days. It gets eliminated. But I think the most important thing to remember is it does not enter the nucleus of the cell, which is where your DNA is, so it doesn't have it, unlike, by the way, hepatitis B, which actually goes in and occupies your DNA. So it's much less than, it's not related even to the infection by a virus. So it's really a very novel idea of actually, it's a messenger basically, as it is. It's just using it as a messenger to do this. And you actually then, instead of injecting the protein, use that messenger to produce the protein, which then comes into contact with your antibody producing cells or your immune cells, which will then subsequently produce antibodies. So there is no concern about it having any kind of genetic impact. It's just the name is probably concerns people. So that's a quick lesson in genetics from a non-geneticist.
We spent 1 hour in this interview, so I will ask you the last question and let you go because I can't allow myself to keep you more than 1 hour.
Fine. I enjoyed talking to you.
The influenza, where did it disappear? When will it reappear? And are you already vaccinated against influenza this season?
Yeah, influenza is, for the pandemic, we kept preparing for a pandemic of influenza. We were surprised by corona. The influenza, now, when we were very worried about influenza, now we say, well, influenza is much more friendly than coronavirus. It's actually a lot easier to prevent outbreaks or pandemics, or at least outbreaks of influenza, because it doesn't spread as easily. If you talk about that so-called R value, which you give as a way how much it spreads, so it'll be a relatively low R value. It doesn't, whereas the coronavirus spreads almost like measles. It's very easy to spread and it's probably aerosol and so on. So wearing masks and just separating, social isolation, is actually a very good way of preventing influenza. And in fact, that was seen in Hong Kong. Early on in the epidemic, when COVID started in Hong Kong, they were in the middle of an influenza outbreak or whatever. They started putting on masks and you just saw their numbers dramatically dropping. I mean, they just crashed. No more influenza in Hong Kong, just suddenly. It looked like there was a mistake in their data. The virus doesn't. So that's probably what has happened in the world. We just interfered with the spread of influenza. So now, your question is, what's going to happen now that we are not using masks so much, although I hope people still do. Well, if we take all those restrictions away, the virus is still probably around. The influenza virus is also a sneaky kind of virus. It disappears for a while, but it hides somewhere and then it comes back again. So it's probably still around at a small, very low level. So now we have a population that's that hasn't been exposed to influenza for quite a while. So it is possible that we've lost a lot of what might be some natural immunity to influenza. So that means maybe that we will have a bigger outbreak in the next influenza season because there'll be less, particularly in the older people, because they haven't been exposed for a while. Or maybe you could argue even in the younger people. My advice, although it's probably not going to be taken, is that in the winter months, we should continue to wear masks and do some social distancing, and we'll reduce dramatically the influenza because we've shown it can be done. So actually we have a proof of concept from COVID that we can actually reduce dramatically influenza. So if we combine the vaccine with some masks and a little bit of social distancing, couple of months a year, maybe just November to January or something like that, we may see much less influenza, but it's probably going to come back. It doesn't, influenza, you know, in 1976 is the last point. In 1976 or 1977, actually, there was an outbreak of what was called the Russian flu, which you might remember. And the Russian flu was an H1N1 influenza virus that had disappeared for 20 years. Nobody actually saw cases, and it came back. So it was hiding in the cupboard somewhere, and it came back after about 20 years.
And the very, very last question is, some people are saying we shouldn't be worried of measles because the pandemic of coronavirus pushed out all viruses and measles will not come. And we have a lot of unvaccinated children against measles and adults, of course, as well. So are we risking an outbreak of measles, or corona pushed measles out and we can be calm?
You know, it's the same answer, and it's very dangerous thinking. It's just like, as I said, you know, when we put all these precautions in, it's true, we actually interfere with the spread of other viruses, like the rhinoviruses and the RSV and all the other respiratory viruses. And measles is also a respiratory virus. So with all the restrictions in place, we probably are reducing the spread of measles. But once those restrictions go away, and you can see now that in Europe, in the UK, for example, they've eliminated all restrictions. I'm sure now you'll start seeing other viruses emerging because there's no, viruses are cleverer than us, as you know, and they'll spread whenever they have the opportunity, they'll spread.
Manfred, thank you so much for this interview. I hope to see you soon in the series 3 when we will have more data on some new things. I want
to come and visit you in Kiev. I miss you all.
We are waiting for you in Kiev any moment when you decide to come.
Great.
And I think that we can, actually, can you travel to Ukraine, or it's forbidden? We are the red zone for you.
We may be still a red zone, I'll check out, but it's, I'll get there.
So thank you very much. See you in Kiev then soon.
Right.
Всем спасибо, кто нас смотрел. И извините за то, что мы выпадали со связи, но так бывает с интернетной связью. Увидимся скоро. У нас будет очень много интересных интервью в ближайшее время. Всем пока.
Thank you, Katya, and thanks to everybody.